Budan initiative from ISA Pudukkottai branch. The outset, we are having our I invite our Honorary Secretary, Dr. Periyaswamy, to deliver the welcome address and introduce us.
Thank
Over
you, sir.
to Dr. Periyaswamy.
Thank you, sir. Good evening. On behalf of ISA Pudukkottai, I welcome you all for this 42nd online ISA webinar program. This is the coldest program in the year. 42nd program. This is 42nd program. We are continuously conducting this program. This online ISA webinar program. It's mainly focusing for the PGs and practicing anesthesiologists to update their knowledge in the field of anesthesia. So it is named as Pudukkottai Budan, and this Pudukkottai Budan, since because name it as a Budan, it is the rate is going up like a gold. This is because of our academic chairman, Dr. A.L.M. sir, for his effort and hard work to guide us to conduct this program continuously, successfully for the first 10 months. So once again, I welcome you for this program. So already we conducted so many programs in so many various topics, from renal transplant to this week, the 42nd program. Today we are having 3 topics. One is basic understanding of research methodology, and another one is scientific paper writing for publications, and a basic of statistical tools. These are 3 topics we are having today for this lecture. For that, so for this program, I invite Dr. Bala Bhaskar, the known professor, Dr. Bala Bhaskar from BIMS, Ballari. Sir has already attended this program for 3 times as a speaker and as well as a chairperson. Once again, I welcome you, sir, for this program on behalf of ISA Pudukkottai. And speakers, today we are having 3 speakers. One is our ISA editor, Dr. Ragesh Kaur, Professor Onco Anesthesiology, AIMS, New Delhi. Sir is going to talk about basic understanding of research methodology. I welcome you, sir. Next speaker, Dr. Anju Griwal, Professor and Head, AIMS, Bathinda, Punjab. Madam is going to talk about scientific paper writing for publication. I welcome you, madam. And third speaker, our resident, Dr. Sivangi Tanju, DM Senior Resident, AIMS, New Delhi. Madam is going to talk about basic of statistical tools. On behalf of ISA Pudukkottai, once again, I welcome you all for this online ISA program. And on this first 2023 ISA program, I welcome our academic chairman, especially for this successful conduct of this program and guiding us to conduct this program on every week without any interruption. I welcome you, sir.
Dr. Periyaswamy.
This slide is not okay. Any doubt, you can send your queries to the ISA pudukkottai@yahoo.com email ID. And today we are going to talk about topics related to research. Small poem about that. Research, exploring the nature by knowing its worth. Engaging the truth with the everlasting faith. Research testing to determine the value, thinking something that may value. Research born when apple fell down, but research fell down when atom exploded up. But research moving around the world, serving humanity in mind with love and passion. With this, I once again welcome you all for this ISA program. Wish you all happy New Year on behalf of ISA Pudukkottai. Thank you for the opportunity. Over to President Dr. Suresh Kumar, sir. Thank you, sir.
Thank you, Dr. Periyasamy. Once again, as President of ISA Pudukkottai branch, I welcome you all for this webinar and gathering. On behalf of ISA Pudukkottai branch, I extend warm wishes and greetings for this year 2023. And this is our first webinar of this year after a long 10 months of academic activity. At this outset, I thank our academic chairman who made this possible. And we have witnessed so many eminent personalities all over the country shared this platform of webinar by as chairperson as well as resource persons. And today we have going to cover an important topic for the postgraduates, practicing anesthesiologists, and overall interest in research, how to go for this research methodology and how to write a scientific paper and what are all the statistics tools available for us. It's a very, very basic topic. And I just recollect, we have witnessed all the topics regarding anesthesiology. I think we are yet to discover some new topics. Our academic chairman made possible every topic available in the textbook as well as in the examination paper, so that this academic Pudukkottai webinar academic program is of immense useful for all the anesthesiologists the past 10 months of this year. And now we have our chairperson, Professor Dr. Bala Bhaskar. We all know very well, is an active ISA person as well as an academic person. We are very privileged, sir, for your visit here as a chairperson. I welcome you, sir, again.
Thank you.
And Professor Dr. Ragesh Garg, who was known to us because he came all the way to Pudukkottai for our branch inauguration. And I remember his active participation in the ISA program. Once again, I welcome Dr. Ragesh Garg from AIIMS, New Delhi. We are very happy to receive and welcome you, sir. And Professor Dr. Anuja Griwal, also from AIIMS, Punjab. She is going to talk on scientific paper writing and how to publish a scientific paper. I welcome you, madam, for this program. And Resident Dr. Shivani Ganju from AIIMS, New Delhi. She will enlighten us about how to approach the statistics tools, which are always a conundrum for us in our medical field. And on behalf of ISA Pudukkottai branch, I welcome everybody here who have gathered here and make use of these topics. And I now hand over the proceedings to our academic chairman, Dr. A.L. Meenakshi Sundaram, sir. Over to Dr. A.L., please.
Thank you, Dr. Suresh Kumar, President ISA, respected President, Secretary, and members of ISA, and there is distinguished faculty across the country. So first of all, I wish you a very happy New Year 2023. And I am personally, as well as ISA Pudukkottai person, I am extremely happy that this is the first webinar. Even before the faculty starts the scientific session, the delegates touched 110. So 110 is a magnificent figure that shows the quality of Pudukkottai Budan as well as the faculty as well as it is a first session of this new year, and because it is a different topic, all the postgraduates would have joined this. That is the reason why now it is 1-1-12. So just like cricket score, आगे आगे बढ़ती चलता रहता है, that is, it is increasing. So I thank Dr. Balabhaskar, Dr. Rakesh Garg, Dr. Anju Grewal, Dr. Shivangi for making this as a wonderful program. And instead of introducing the audience just like that, for these 115 delegates who are attending this program, I want to tell Dr. Shivangi is a postgraduate from AIMS, New Delhi, and she was trained by Dr. Rakesh Garg. And when I asked Dr. Rakesh Garg how he has trained her, because she seems to be very intelligent, Dr. Rakesh coolly replied, I am not training her, she is only training me. So that is the credit that a postgraduate possesses. And see, postgraduates, they find it very difficult to do the thesis, research topics. That is the reason why I requested the chairperson and Rakesh to start this new year with the statistical webinar and the research methodology, and they have readily obliged. In this case, a postgraduate talking about the scientific tools, statistical tools, it is something wonderful, and we are really happy. And as a matter of policy, Pudukkottai ISA introduces young faculty. Postgraduate is compulsory for us. And even I was requesting Dr. Rakesh, if it is difficult for a PG, you can have one assistant in that area. I will compensate with 2 postgraduates in the next webinar. But he is very confident. No problem, sir. Just like that, he said, no problem, sir. We will do it. See, he has done it within a day. In that way, I am very happy. But he has taken 5 days to attend my phone call. So even after that, within a day, he has covered it. That shows the confidence he has over Dr. Shivangi. So I welcome her. So it is followed by Dr. Anju Grewal. Sorry that her name is printed in one flyer as Anuja Grewal. So our president also mentioned that Madam is Dr. Anju Grewal. Another flyer was right with that spelling mistake we have corrected. So Madam is we cannot compare her with anyone. So she's a master blaster in all the conferences. So the way in which she delivers the lecture, it will be simply magnificent. All this now it is 124. This is the topmost figure we have, because previous highest number was 118. But now it is 124. Even before the starting of the match, 124 people have assembled. So Dr. Anju Madam, she is very good at pediatrics. She is very good at obstetrics, and she is very good at the research methodologies. Whatever you say, she is very good in everything. Even in behavior, she is too good. And she will be very much humble, and she will say, I don't know anything. So Madam is extremely good. And I want to inform all these distinguished delegates that you are having a topmost faculty, not only in the country, internationally. People will be waiting for your date. So, but Madam readily obliged within a day. Madam has obliged. Even we have requested Madam to come for another session in our webinar. Yesterday only I talked to her. She has to come again. She has to expose her expertise to all the youngsters. So I thank very much Dr. Anju Grewal, who is a professor in Bathinda, Ludhiana, Punjab. And I am very happy. I have visited Ludhiana. I have visited Amritsar. I have visited that DMC Ludhiana. Madam was there initially. She was graduated from Bhopal actually. She is working in Punjab. She is a known topmost faculty in the country. So I thank Madam for readily obliging us. So the man today, the person who has arranged the webinar is Dr. Rakesh Garg. Dr. Rakesh Garg is not new to ISA Pudukkottai. He has traveled all the way from Delhi to Pudukkottai to deliver the lecture on cardiac resuscitation. So he knows all the members of Pudukkottai. But now what I want to convey to, I think many non-anesthesia members are also there. So Dr. Rakesh Garg is presently the editor, Indian Journal of Anesthesia. He is the chief editor. What I want to convey, we have selected the topmost person in the country to talk about that research methodologies. He is a editor, Indian Journal of Anesthesia. He is a professor in All India Institute of Medical Sciences. Wherever a journal is there, he will be there. So if I quote his publications, this day will not be enough. He has published more than 500 papers, nationally, internationally, everywhere. But he is also a down-to-earth human being. He was the one who introduced me Golgappa in Delhi. People used to take us to the five-star hotels. But I asked him, I want to taste the food, local food. He has taken me to a good vendor, Golgappa. I cannot say that it is a hotel. And he demonstrated me what is Pani Puri, what is Golgappa. So many things I have learned. And he has never taught me anesthesia because he knows pretty well I cannot learn anything up to his standard. So he omitted anesthesia and he taught me all these snacks item in this. So he is such a nice man, ever smiling. And so what the best problem we had was to tackle this Dr. Anju Grewal and Dr. Rakesh Garg. We want to have a chairperson. That is a problem because he is the chief editor of Indian Journal of Anesthesia. Then we approached Dr. Balabhaskar. So everyone should know now that figure touched 137. 137. Dr. Balabhaskar is a previous chief editor of Indian Journal of Anesthesia. That everyone should know. So two editors are here now. And more than that, Dr. Balabhaskar is the national president of Indian Society of Anesthesiology. So he is the past editor. He is the past president of Indian Society of Anesthesiology. And he is a professor in WIMS Bellary. He knows Tamil also. That is the part of it. He is in Karnataka. But he knows very well Tamil. He is also a nice human being. Just like that, he will move with all the people. But here I want all the delegates to use their expertise. Very, very difficult to catch them. So you have two editors. And Madam is a Punjab Journal editor. So you have all the faculty. And Dr. Shivangi may be the future editor of IJA. We don't know. So please make use of the facility which ISA Pudukkottai has provided to all the delegates. So I have taken so much of time because now the figure touched 139. Phenomenal. I think it will be an unbeatable record. So thanks to Dr. Balabhaskar, Dr. Rakesh, Dr. Anju Grewal, Dr. Shivangi, you are sharing a wonderful platform which is having 141 now in the Zoom platform. So please make use of this opportunity. Dr. Balabhaskar sir, now with the profuse thanks and enthusiasm, I hand over the session to you for the scientific proceedings. Thank you, sir.
Good evening and vanakkam to all my colleagues from ISA Pudukkottai, President Dr. Suresh and of course Dr. Periyaswamy. It's the program which was basically initiated by Dr. Meenakshi Sundaram, but the team effort always shows. We have the team of ISA Pudukkottai which has been so active and reaching about the 42nd session since the last year is a huge achievement. Congratulations to the team. And of course, Happy New Year to all the participants, the members of ISA Pudukkottai, then all the audience here today. And of course, I have three colleagues here who have been actively with me in the academic activity in the last about 10 years. So, of course, the new entrant is Dr. Shivangi. So, Dr. Meenakshi Sundaram was the vice president and active in our ISA National as GC member and an active academician, and he is a well-known orator in demand everywhere. So when he arranges a program like this, the demand should definitely go up. It has reached now 144. It could be 200 also now. So nothing surprising because of his quality in terms of medical knowledge as well as the knowledge in Tamil, as he was telling. Congratulations, sir. And you have got, when he said editors, we have Dr. Rakesh Garg, the current editor-in-chief, and Dr. Anju Madam is the ex-editor-in-chief of the JOCP, Journal of Anesthesiology and Clinical Pharmacology. So both of them are endowed with rich knowledge in research methodology and publications. It is one field and one class where people who are active in this particular specialty are here. Thanks to Dr. Meenakshi Sundaram and the ISA Pudukkottai for inviting me to this program. And of course, we had introduction about Dr. Shivangi also, a young lady, young academician from AIMS. So we have a sequence which is logically placed. Dr. Rakesh will first speak about the basics related to how to conduct the research. This is followed by how to prepare the publication aspect, manuscript and other things. And the statistics would be dealt with as a separate class because it needs to be taken up as a separate session. So that way it is going to be a very beautiful session. Again, I request all of you to actively participate and exchange questions in the chat box. Okay, we will take up all the questions in the end so that we all 3 + 1 + 1 means the fifth one is Dr. Meenakshi Sundaram again. All of us would participate in the question and answer session. Thank you very much. So I think we can start with the first presentation by Dr. Rakesh. It is.
Thank you so much, sir. Thank you so much for the kind words, Balabhaskar, sir. Thank you, Dr. A.L. Meenakshi Sundaram, sir, the academic chairman and the past vice president of ISA. And I think he has multi-dimensional things to his credit. He's just not an anesthesiologist, but he's much more than that. And he's well appreciated and renowned in many other aspects apart from anesthesia. And also thanks to all the ISA Pudukkottai branch office bearers for their kind words and kind invitation. And special thanks to Madam Dr. Anju Grewal, because it was actually a short notice, just a 2 days notice, but she never says no to me. And again, this time also she agreed in spite of her busy schedule. And thank you, Shivangi, also. Again, a short notice, but she was ready to be with me for this session. So we'll move towards to our actual session today. And when we are talking about the research, I think research is one of the basic aspects for not only the postgraduate students, but also for the undergraduate students, because anybody who enters the medical science, whether they are researcher or academician or not, or they are simply clinician, but it is equally important for all the clinicians, all the healthcare professionals to understand the basic aspects of research methodology. Because even into your clinical practice, when you see a paper and you want to have some, bring its facts into your clinical practice, you need to have those basic understandings that whether this research has been done as per norms, as per criteria, and whether we should translate this research into a clinical practice or not. So maybe in today's 1.5 hours, we will try to take you through the basic aspects, because otherwise it's already a 2 to 3 day full day workshops when we talk about the whole research process, but we'll try to make you through the basic understanding. I bring greetings from my institute. I work at AIMS, as Dr. Meenakshi was mentioning. We have 2 onco centers, one attached to the main campus and one attached to the little outside campus. One is around 300 bed, the other one is 700 bed specialized onco centers, which are functional. So when we talk about the research process, let's see what the steps are. How do we start the research? Now, first thing is, when we have some query in the mind or some dilemma in the mind, or we are looking for some new technology, some new drugs, some combination of drugs, some change in the dose, some in the route, we need to have a review of the literature to look for that is there an already available something better that we can do. If not, then probably this will make us think of something different, and we need to prove it. And probably this requires a research. And this, the review of literature, your experience, your lacuna in the existing clinical scenario will help you to formulate a research question. And then based on this, you will select an appropriate research design. I know this is important because there are many research designs which are available. I'll just show you a glimpse a little later. But each question probably has some specific, each question needs to be answered using an appropriate research design. So this is very important, because if you choose a wrong design, probably whatever you do, whatever the outcomes of your research comes out, probably they may not be so much acceptable if the research design is not good. Once you have a research design, proper methodology has been created, approvals has been taken, you start the study and you collect the data. Once the data are there, you try to interpret the findings and then publish it. And then this published finding probably becomes a review of literature for future research, which are based on the limitation of the research that you have done. So this is a nutshell we will be taking it through. So probably today we'll be talking about method section, we'll be talking about publication, and we'll be talking about how to use the statistical tool, whether for research or publication or even for understanding a published article. Now, first thing is, whenever we think of a problem to our clinical practice, we have to be very clear about three things. What would be the aims and objective of our study? What would be the research question which should be explicitly defined? And what hypothesis would be there, probably based on your experience, based on the review of literature. Now, when we say objectives, objective needs to be very clearly defined into your study. And when you define your objective for a study, it should follow certain criteria, and you can remember them by this mnemonic SMART. This means when you say an objective for my study is, it should fit into those 5 parameters. It should be specific. For example, if you are looking for the reduction of pain score by some intervention, maybe some block, maybe by drug, so it should be very specific as saying pain score as measured by a numerical rating scale or visual analog scale. It should be measurable. You cannot say that pain reduction by mild, moderate to mild, or severe to moderate. So this may not be an appropriate measurable one. It should be objectively measured. And hence we say a visual analog scale of, say, reduction of 5 will be of clinically significant. So this is measurable, attainable. It should not be so much of hypothetical that you say that by giving this drug, no patients will have any amount of pain. So, I mean, this is one aspect. So you will not be able to get these type of magic drugs, or the type of patient that you are looking for may not be there. So this means whatever you do, it should be attainable into your clinical setting. It should be relevant to your clinical practice, and it should be time frame. For example, if you start a study and you think that study is need for the day, and you make a time frame of say 20 years, probably it will not be so useful because you require that study for today. So you have to frame this objective so that the time frame is appropriate for your study, and in that time frame, whatever the outcome comes, that will be suitable for you. Now, coming to the research question, that how do you frame a research question? So whenever you think of a research question, think of certain criteria that how my research question should be, or what should be the basic ingredients of my research question, or what should fit into the research question. So I think again, this nice mnemonic FINER is good for you to understand when you frame a research question. And this FINER stands for 5 aspects: feasibility, interesting, novel, ethical, and relevant. So whenever you frame a research question, think that whether it is feasible or not, with regards to time, the staff, the funding, the available infrastructure, the sample size. So just to have a preliminary understanding that these are available to you. Interesting. If you want to do a study, you should be interested to do the study because it requires a lot of effort, a lot of time, a lot of manpower. So you should be doing something which is interested to you, maybe for funding. And in the other sense, it should be helpful to the patient population also. It should be novel. Novel means if something has already been proven in the earlier research, so there is no fun in doing it again. So there should be something which confirms, refutes, or extends previous findings and provides some new finding to it. So there has to be novelty because the research involves various ethical issues, the patient involvement because you are studying them. So they should not be having the same research question being answered, which has already been proven because you are taking patients as in subjects here. And that's why it should have some novelty. Ethical. Whatever you do should be ethical. We will be taking this a little more details subsequently. And relevant to your clinical practice, to the scientific knowledge, or it change some policy patterns or some improvement in the basic management. For example, if you remember a very previous study, which was the supplementation of zinc for small kids for the prevention or treatment of diarrhea. So this was a landmark study which was done by an Indian author. And this has actually changed the policies of management of diarrhea in pediatric population. So this means sometimes we have to think of these simple maneuvers, measures, drugs, which can have an impact on the health policies also. Now, once you have taken the topic of a research question, now you have to frame a research question from it. And what should be the components of research question. So it has usually, conventionally, it has 5 things which must be a part of your research question. It is remembered as PICOT. P stands for study population. You should very clearly define that which population are you including into a study. For example, adult patients undergoing laparoscopic cholecystectomy. So it has to be properly defined. The intervention to be tested. So whatever, whether it's a technique or a tool or a medication or a route, it should be clearly defined that these patients will receive, say for example, patient-controlled analgesia using fentanyl in these patients. So your intervention should be very clear. If it's a technique, say probably you want to look for this patient will receive erector spinae block for patients undergoing thoracotomy. So the intervention should be clearly defined, and not only this terminology, but subsequent in method section will come a little later. It should be described at how you will be intervening by your technique. Control arm. Now you have to compare your new intervention or a new drug or a new technique with some standard of care. Either it could be a gold standard or it could be a standard of care. So this has to be defined into a study very clearly. The outcome. Again, outcome, as I mentioned earlier also, the outcome should be very well defined into your study, and it should be an effort to have an objective parameter so that the bias comes down. And if you're using certain tools, it should be a validated tool. You should not be creating a newer tool or newer measurement strategy for the first time into a research. For example, if you want to look for the sedation, you can have Ramsay sedation score. If you want to look for the constipation, you can have grading of constipation. If you're looking for pain, you can have visual analog scale or numerical rating scale. So these are all objective parameters. These are all validated tools that needs to be used and must be defined into your research question. The timing of measurement of outcome. Now, this is again very, very important because you need to define that whatever intervention you have done, the outcome in some intervention will be immediate, some will be a little later in hours, maybe sometimes days also. So you have to define that the outcome parameters that you are measuring for the effect of the intervention should be measured at a particular time that is based upon the intervention. So this is what you need to remember now, that you need to have a SMART objective. You need to look for the finer criteria for a research question. Once you finalize it, try to frame a research question, and it should have PICOT. So these are the important understanding of the method section of the methodology, and this will be equally important when you go for your publications also. Now, once you have this research question is ready for you, now you have to translate this research question into a doable format. That you have to now conduct a research. So you have to have some approach to conduct that research for the research question or hypothesis that you have generated. Now, when we say methodology, it has to be in very much detailed so as that if somebody wants to do it again, they can do or they can replicate absolutely in a similar way as you have done it. So each step, for example, if you are using a drug, you have to mention the drug, the route, the dose, the frequency. If you are using a block, you have to mention whether it's a blind block or a nerve stimulator guided block or an ultrasound guided block, the drug, the concentration, the volume, and the endpoint. So this means each thing in the method section should be described to the fullest. And if your methodology is such in a detailed way, then only you can assure that the hypothesis will be proved or disproved using the right tools. So this is what we mentioned, and we'll be discussing into subsequent session also. Now, once you have a research question, each research question requires a specific study design, and that needs to be looked for. If you look for the various study designs, if you just look for the various research as such, there could be primary research or secondary research. Secondary research will leave for today. It is primarily systematic reviews and meta-analysis nowadays, which are more common. But for primary, it could be a basic research, which many times the undergraduate students are very much interested in it. Clinical trials, again, the clinicians are they are very much interested to these type of experimental trials. And epidemiological trials, even those who are epidemiology or undergraduate students, they try to do these type of epidemiological trials, usually in a community medicine practice. So once you have, then you can try to look for. Now, how to look for these various type of designs here? Now, when we say study design, I mentioned earlier that you need to have a research question, you need to generate a hypothesis. Now, how this comes up? Now, whenever there is something new which appears, maybe a technique, maybe a drug, maybe a route, usually they are reported in the form of a case reports to share their ideas for the first time. And then these case reports are accumulated, it becomes a case series, and then a descriptive epidemiology. Sometimes they require animal studies. And then finally, once this analytic epidemiological studies hints, it generates an hypothesis that yes, this technique or this drug is benefit than the other standard of care. Then you try to do a clinical trials. Now you have to compare with standard of care or the gold standard. And this is what is hypothesis testing. And then you can do it in the base of a case control or a cross-sectional or a cohort study. And then finally clinical trials where you prove or disapprove based on your existing standard of care. Now, depending upon, as I mentioned about the research questions, so there would be a various research questions which are available with. If you are looking for burden of illness like prevalence or incidence, probably cross-sectional surveys or longitudinal surveys are required for that. If you are looking for the causation, risk, and prognosis, that whether with some intervention, with some technique, there is some relation with them, you need to do a case control study, or even cohort study in RCTs are applicable for you. But if you are looking for the treatment efficacy or diagnostic test evaluation or cost effectiveness of a newer technique, RCTs are the best drugs because you are comparing with a standard of care or a gold standard one. For this, you require a randomized controlled trial, and there remains one of the robust study designs for confirming a treatment efficacy or a diagnostic test evaluation or a cost effectiveness of technique, which is very, very important, especially in Indian scenario. So just to summarize once again what I have just mentioned, that a descriptive studies gives you a hypothesis, case control studies investigates its relationship to the outcomes, cohort study defines its meaning with the various exposures or confounders in fact, and then subsequently you test the link experimentally and they are labeled as clinical trials. And this is what you do, you choose your study designs depending upon what research questions have you developed. Now, once you are ready with your research question, you are ready with hypothesis, you are ready with study design based on the information that I just showed you, you need to look for the study period. Do mention your study period, approximate study period when you plan it, because everything needs to be disclosed. You also need to mention the study.
My audio is so. You have to reduce audio. No.
May I request the participants to just mute themselves? The study area is important because if some patients are being selectively coming to a particular center, the outcome of your study may not be generalizable. For example, say a tertiary care hospital, only probably a difficult patients are coming there, the advanced disease patients are coming there. So whatever the outcome comes from your tertiary care hospital probably may not be applicable to a primary care centers, depending upon what your research question is. And that's why it becomes important to define the study area when you write a protocol or conduct a study. The next important aspect is selection of the study subjects and participants. Now, how do you select your subjects and participants? Once you have a research question, we mentioned you have to have a population. That population needs to be defined, and that population needs to be defined based on your interventions. Now, it has a criteria for inclusion or exclusion. Now, when we say inclusion, you need to define that which population. For example, say adult patients undergoing laparoscopic cholecystectomy. Now, this will be, we say adult patients. But if you think that you don't want to include patients more than 65 years of age, you have to define adult means here you have to define 18 to 65 years of age. Now, again, you probably sometimes based on your intervention, they may have adverse impact on certain body systems and you want to rule them out. For example, you are looking for a drug which may have CNS side effect, which may have depression, which may have, say, sedation. And that's why you don't want to use these drugs in patients who have some CNS disease. So probably now you need to exclude these patients from your disease. So remember that exclusion is from the patients that you have included into a study. Sometimes very, very commonly we mention that patients from 18 to 65 years will be included into a study. And then in exclusion, we say less than 18 years and more than 65 years excluded. No, this is not the right way of writing a protocol. It has to be, exclusion should be from those patients you have included. Now, also you also need to define that in interventions, how will subjects be allocated to induction comparison group? So this means you have to mention about the randomization, which I'll come a little later. You also need to look for the criteria for discontinuation. Because once the patient is recruited into a study, they are randomized, you have to follow them up for the endpoint of your outcome. If you remove them, then a problem happens because maybe that patient is more sicker. Maybe that patient is not affected by your intervention. Maybe that patient gets much better and that's why he's removed. So the criteria for discontinuation must be mentioned into a study that if the block failed, if the airway is failure, these patients will be excluded or not. So this has to be defined a priori. And now we have different concerns. Probably we'll discuss a little later when we say that no patients after randomization should be excluded because these patients may be much better or much sicker. And hence we should not be removing them from the analysis to understand the impact of our outcome. The other aspect is planning for the data that you receive. Now, this data, whatever you is collected, they are compiled, they are entered. This is very, very important when you do a method, when you write a protocol, that how is the data being collected, who will collect the data, whether, for example, say if you have to collect the data by monitoring the blood pressure in the post-operative area, somebody needs to mention it very clearly that data will be collected by a person who is experienced in collecting blood pressure. And you need to define those tools that how you're doing it. And also you need to mention about the data cleaning and the analysis plan, the statistical analysis, which we're discussing in subsequent section. The other aspect is the tools, terminologies, and orientation training of these things needs to be mentioned very clearly. That which tools will be. You cannot say in your protocol that the blood pressure will be measured, the pain score will be measured, the quality of life will be measured. You have to mention that what validated tool will be using, and if you are using some terminology like sedation, like seizures, like say. If such type of terminologies are being used, you have to define them clearly that yes, sedation means this, or failure means this, success means this. So this has to be clearly mentioned into your protocols. The study tools should be a priori designed, but it has case record forms in which you need to collect the data. And the instrument tools preferably should be, as I mentioned earlier, it should be standardized tools, it should be validated tools, and they should be cited appropriately. For the first time, you should not be including the tool for the first time which has not been validated, because then your outcomes will be biased and you will not be able to use it. Also, you need to define that how your observations, when your observations, and where the observation is made. Describe all the instruments or refers. For example, say you want to measure the blood pressure. You have to clearly say that you will be using the sphygmomanometer, mercury sphygmomanometer, or you will be using an automated blood pressure monitoring tool, or you will be using invasive blood pressure. So it has to be very clear. Again, it has to be clear that blood pressure will be measured in which position: sitting position, supine position, head up position, office position. So it has to be very clear, and hence whatever the instruments and observations, they need to be defined very clearly. Similarly, the laboratory tests, for example, blood sugar. Blood sugar can be done by venous sample, it can be done by arterial sample, it can be done by capillary glucometers. So you have to define them clearly, that what test and how it will be measured, because if you use it differently, the values will be different and it will create a lot of bias. Similarly, many of the times the undergraduate students also do, and even the postgraduates, they use a lot of questionnaires or the interview-based studies. Now, again, these questionnaires needs to be standardized and validated. They are appropriate statistical tools wherein and the method sequence is already there in the literature, that how these questionnaires are developed. If not existing, if they are developed, if they are already validated, you can use them. If they're not, then you have to first make a questionnaire by review of literature, by there certain specific process, and validate this question appropriately, and then validate the tool before you use it for your study. Similarly, the type of interview, sometimes we use a qualitative interviews. It has to describe the structure. Always maintain the confidentiality of your patient population into a study, and take appropriate clearances. Ethical clearance is one, sometimes institutional review board, observational units, animal. So whatever the observations are, those should be clearly mentioned in your study. Now, coming to the variables that are important for your study, you need to understand them. The statistical will be discussing later, just to make you understand that we have to use certain variables to a study. So you should be very clear, because in the third session, when we're talking about the statistical tool, you will be using these, whether you are having a categorical variable or a numerical variable. Now, these are two types of variables that you use. For example, say gender, for example, the severity of disease, they are all qualitative variables. But if you talk about, say, blood pressures, the height, the total leukocyte count, number of patients, there are quantitative variables. Now, qualitative, when they are unordered categories, they are called nominal. For example, say gender, they are all equal. They are called nominal. The ordinal, when they have some categories. For example, the severity of cancer, stage 1, 2, 3, 4. So they have some category. Say one stage is milder one, fourth is severe one. So that's why they have some category. They call ordinal. Quantitative, they could be discrete. For example, say TLC count. So TLC count will be 13,000 or 13,001. Nothing can be in between. But if you say height, say if you say 5 feet 1 inch, or maybe say 160 centimeter, the other is 161 centimeter, then there will be something in between, 160.5 centimeter. Again, there will be something in between, 160.25 centimeter. So this means there will be something in between. So it is like a continuous quantitative variable. So these are how you need to look for. Remember, when you plan a study, you can sometimes make your quantitative variables to qualitative for the purpose of better understanding, but the vice versa is not possible. So be very cautious, because the application of statistical tool will be a little different. And all your variables should be appropriately defined. Like, for example, say age. So you cannot say age at what point of time, it's 365 days. So you have to say age at last birthday. Family size, you cannot say family size, it has to be say number of family members. So you have to have an operational definition for each variable that you mentioned in your method section. Now, next comes to 4 basic aspects of your research: sampling, randomization, allocation, concealment, blinding, and masking. Now, these are all important aspects, especially when you go for randomized controlled trial. When we say sampling, you have a bigger group and you want to select a population out of it, because you cannot study the whole universe. So you have to sample these patients, and sampling should be done in such a way that each volunteer or each subject has an equal chance to be entered into a study. So any observation unit should not have 0 probability, and that is what sampling needs to be done. But it has to be an appropriate sample. Sample size calculation needs to be done. There are certain formulas for it based on this, because if you do a 2 sample size, your outcomes may not be valid. If it's a large size, then it will be unethical at times, uneconomical. And if you can prove something with 100 patients, why to expose 500 patients for the same? So that's why the large size should not be taken empirically, it should be appropriate. Sampling can be of various types. Mostly we do a random sampling, but sometimes non-probability sampling is also required, wherein because of rare disease, because of patients, like for example, say contacts of HIVs. So you have to use non-probability sampling, where you can refer one patient to the other, so that because they have a close group, they can understand. So that becomes important. But this is not a very robust way of sampling from the statistical point of view. So it should be restricted to rare disease, small population, special population, for example, patient with congenital diseases, special conditions, or difficult to reach populations. Now, gold standard is the probability sample, as I mentioned, because it has more generalizability, and this application of statistical tool are much applicable if you have these type of probability samples. And majority of time we use these 4 major techniques of sampling: simple random, systematic random, stratified random, and cluster sample. I'll not go into detail much today, but for all postgraduates and undergraduates, I think simple random sample is the most commonly being done. But sometimes if you think certain parameter into a study is being affected, for example, say age, you can do a stratified random sampling, so that this should not happen that one patient has a younger age group, the other group has a elderly age group, and then your outcome parameters, if they are dependent on age, they will be different. So you can do a stratified random sampling, so that each groups will have strata, and they will have almost equal distribution of this. So what I have summarized till now, you need to have a target population, do a sampling, select the study population from this, and once you have a study sample, you randomize them. And once the randomization has been done, you need to look for the subsequent steps. So what we are doing is, majority of time we need to look for a control group, as I mentioned. Sometimes the initial basic studies, it could be single group. If there is no specific data available, we are doing an exploratory studies. But once we have some data, we can compare with the standard of care or the gold standard and then take it. Now, why these controls are required? Because many of the times when you see your patient, there will be something, a placebo effect. And this placebo effect can be seen in any patients. And that's why we want to have a control group, so that placebo effect is neutralized or balanced in between the 2 groups. And you can take care of this type of confounder. And hence you can look for the real effect of the interventions that you are doing it. But sometimes placebo is not possible. For example, if you're looking for the analgesic effect of a drug, you should not be taking placebo as a control group. You should not say in one drug you will give analgesia, another drug you will not give analgesia, and look for the pain. No. So in this, probably you need to look for something you can use a different drug or a low dose group or a standard therapy or a gold standard. So this must be given, and this is the ethical aspect, that placebo does not mean not giving attention or care or treatment to a patient in control group. It is that these patients should also receive the standard of care to these patients. Now, once you have done randomization for these patients, it enables a fair and unbiased comparison of study interventions, and you need to have equal distribution, and there are many methods of doing it. Earlier, the people used to do tossing coins or chit fund or earbud, but they are not good. Now, most applicable for manual will be a random number table, and more commonly now we are using is a software-based, a computerized method. So these type of quasi-randomization, as I mentioned about, based on date of birth, date of presentation, alternate assignment, chit fund, these methods sometimes can be bypassed. They can have bias and hence should be avoided. And this is how we do for simple randomization using random number table. You choose, depending upon number of patients, you choose a sequence of line, and then based on this, you can choose the numbers. For example, if you choose these 16 numbers here, 20 numbers here, then 1, 3, 9, 6, 2 is the sequence. And you can say that number 0 to 5 will group A, and from 6 to 10 or 6 to 9, sorry, will be group B. And based on this, you can just group them into a randomized sequence. Now, once you have done it, the other aspect I mentioned about the stratified randomization. Stratified randomization is basically when you do a stratification that younger and elderly are grouped separately, and then they are randomized so that each group will have equal numbers of youngers and elderly. Now, once you have done randomization, they again can be biased, because you know that next patient that is being recruited into a study belongs to either a study group or a control group, and you may not recruit him into a study on that particular day because you know the sequence, and hence it can create bias. So that's why the patient need to have allocation concealment, because this can lead to a bias into this. You can exclude certain patients, and then that's why allocation concealment should be done. So this is in very brief overview, you can say this is concealing the randomization sequence that you have from the method of recruitment whenever you are doing it. So this shields the knowledge of forthcoming assignments, whereas when we talk about the randomization, it prevents correct anticipation of future assignments. So both needs to be done for all the patients, and the person who is generating or doing the concealment of sequence should be independent one, so that they are not aware of what next patient group recruitment would be there. There are many methods of doing allocation concealment. Most commonly, we use the sequential numbered opaque sealed envelope. So what you do is you develop a randomized sequence. You write on a piece of paper those sequence A, B, B, A, whatever it is come. You put it in an opaque envelope and you seal it. And then each envelope is numbered as 1, 2, 3. And as and when the patient is recruited, you open an envelope and see the sequence. So this is preventing you to be aware of the group before the patient goes into your study. And this is what the steps of snooze technique is. And this is one of the most acceptable technique for the randomization and allocation concealment. The other thing which can happen is the blinding and masking. Blinding means it's one of the good practice. People earlier used to use labeled as single blind, double blind, triple blind, but these are the outdated terminologies now. What you need to do is you need to blind whatever you can into your studies. You can blind participants, practitioners, data collectors, outcome adjudicators, data analysts, and then you need to disclose into a study that how you are blinding them. Sometimes it may not be possible, then that's why we say you need to have more of an objective scoring system or an independent assessor, so that these things are taken care of. You can standardize a treatment in the groups. You can consider duplicate assessment, and probably it remains one of the limitations if blinding is not possible. Remember, blinding is not equivalent to allocation concealment. Allocation concealment ensures that treatment to be allocated is not known before the patient enters, and blinding is after the enrollment into the study. So both needs to be done so that throughout the study process, you are able to take care of your patients in a blinded way without any bias. Now, a lot of bias and confounders can happen. There can be certain factors which can affect both the exposure and the outcome. And these factors can lead to certain impact on the outcome that you're looking for. So this could be, when we say errors, this could be role of chance or random error, or a bias or a confounder. Now we need to understand that confounder is an externus which is related to both the disease and the exposure, while bias means the systemic tendency of any aspect of your sequence of steps into your research, including design, analysis, interpretation, that can affect the estimate of the exposure effect from your values. So be careful about these bias which can be created at many places. And whatever we do, randomization, allocation, concealment, the objective parameters of using the tools, they are all important. Now, these are the usual bias that you see: selection bias, recall bias, observer bias, measurement bias. So these are the biases that can be creeped into your studies. So be careful with them. Certain things we are able to take by randomization, allocation, concealment, blinding, objective scoring systems, repeat sampling, repeat measurements, and taking the best of them. So these are the tools that needs to be taken care for your management. Now, confounding is, as I mentioned earlier, if there are certain factors which affect your exposure or outcome, is major issues. For example, we know that coffee consumption leads to the occurrence of pancreatic cancer. But it is usually seen that if somebody is a coffee consumption, he may also be a smoker. So we can say smoking increase the coffee consumption, and smoking also increase the pancreatic cancer. So this means here smoking is a confounder because it is affected by both the exposure and the outcome, and hence we should take care of this confounder in both the groups that you are studying it. Either we can exclude all the patients of smoking, or we need to compare them, and that becomes very, very important. So for any confounder, it must be associated with exposure and outcome, and must not be in a causal pathway. If you found certain thing, those like for example smoking, you should be careful for your study. Validity issues. Now, why we say the study is valid? We say internally validity and external validity. So when we say the validity of your studies, this means when you try to define your method section in such a detail that if somebody can replicate it exactly in the same way, then probably, and you are taking care of all the biases, all the confounders, and you are measuring very objectively, and everything is very clear and transparent, probably the internal validity of your study is much better. And when we say the external validity, when I was talking about the sampling technique in the beginning, we say when you do a sampling, you should do in such a way that whatever, because you are choosing a sample from the whole population, so you should be able to extrapolate your findings from the selected population to the population in general. And this is what is the external validity. If you think that your selected population is not matching with the general population, probably the external validity is not good for your study. The statistical analysis will come into a subsequent session. We should be very clear about the ethical principles of research. I may not be going into detail, but you should follow all the ethics of integrity, justice, dignity, autonomy. All things needs to be taken care for your study. Now, these are the reporting guidelines you can easily see on the Equator platform. And for each type of study, for example, RCT, there is a consort. You can go on this site and you'll be able to see that what all things should be there into your research or your protocols, what steps should be there, so that this makes your studies much better. Again, this is a nice framework where you can think of which type of study should be selected for particular research questions. I think I've already described it, but this nice flow chart will help you to choose a particular study design. So to summarize, a well-planned and well-designed study with acceptable and repeatable outcomes is only possible when you take care of the steps that I have just discussed with you, so that whatever you do, whatever the outcomes are, they're applicable to your patients, and you can improve the care of your patients much better. So thank you so much. And I think over to Dr. Balabhaskar, sir, whether questions now or later.
Yeah, Dr. Rakesh, thanks a lot. It was comprehensive, but and also conveying the meaning to the participants within the limited time. As you were telling in the beginning, it's probably 4 or 5 days of workshop, and we are trying to compress into about 40 minutes of presentation overall. So let us take the question at the end. So, and try to collect the questions in the chat box also. Now, I think we can assume that research is conducted and completed, data is also collected. And the next class would be from Dr. Anju Grewal. She will be talking about how you can prepare this manuscript for publication. and what are the techniques. And being a past editor-in-chief of JOSCP, she is well placed to present it in a proper way to all our participants. Madam, please, you can start sharing the slides and present.
Thank you so much, sir. Indeed, my thanks to the entire team, especially Dr. Meenakshi Sundaram, sir, Dr. Balabhaskar, Dr. Rakesh, and the entire team up there for having me up here. Sorry, I think are my slides visible and am I audible?
Yes,
ma'am.
both are perfect.
So I'll try to, I think my job has been made much easier with Dr. Rakesh Gar taking you in detail through the whole, scenario of how to do a research. Now, what we're going to look at is in another 20-30 minutes is to look at how to write this paper up there. I bring you greetings from the new place that I'm now working at AIIMS Patina in Punjab. So, reading makes a full man, conference a ready man, and writing an exact man. And we all know that, we live in a publish or perish culture. We have the NMC guidelines that necessitate that, our promotions are based on research. And more than that, whatever the research that you have done has to be disseminated so that, it can be kind of applied to clinical practice and after a lot of data has come onto a particular research question. And of course, systematic analysis and meta-analysis can then arrive to the fact that whether or not we can use the results of our research to clinical practice. So that's why, publishing is so important. Yeah, and as I told you, career advancement is, of course, one very small little aspect, but the most important is that we really need to share our results so that we can really have better outcomes for our patients and more safer outcomes. So, as he said, before we start writing, the basic core of any good paper is how well you have designed your research, and that is what has been taken so well by Dr. Rakesh Gar. So we need to, once you have done your study or you have, kind of made your protocol and you have started your study and you have results coming in, now is the time that you simultaneously start to think and what are the journals that you're looking for. So it will all depend upon the kind of research that you're looking at. Is it something that is an original or a novel study, or is it, it's an whatever kind of a study is it interesting to the readers of that journal? So you really need to select a journal that you want for your study. So therefore, you need to look at the journal, the audience that the journal caters to, the kind of articles that the journal caters to. And this will help us, understand which kind of journal we look for. And other aspects are that we also looking at improving our, our statistics, especially the impact factors, our H index. So we will like to look at a journal which will, take our research into a better perspective, will have wider dissemination into our scientific audience and our scientific community. And what most important is to remember that, none of the editors, and I'm going to have our perspective as well. So as an editor, when I look at it, we would not like to have any legal or ethical hassles. So you need to be very clear on what kind of journals and what kind of paper am I carrying that would be acceptable to the journal. Okay. So what makes a good idea is something that Dr. Rakesh has said, which is something novel, compelling, innovative, relevant. He talked about the final criteria of how to design a research, but what we are basically looking at is something that is something novel. As an editor, we were looking at a research that talks about a research question, which is not redundant, is not duplicative of previous study, is actually looking at a gap in the knowledge that we have, have up there. Okay. So the right format for your kind of publication is very important. So as if it is a research paper, you've done a study, it's a randomized control trial, it goes into the research paper or an original paper section. If it is talking about a particular case, a novel case that you have done, that it might go either into a letter to editor or a case report. And of course, editorials and reviews are usually invited by editors So you will get an invite to write on a particular topic, and that could be a narrative review where you will collate the data that is already present in the scientific world, and then, or you might be invited to do a systematic review in a meta-analysis. Okay. So based on the key message, based on what kind of publication material you have, and the kind of audience that you want to reach out, and the kind of reach that you want to add up, you will decide the kind of journal you're going to pick up. Now, once you have picked up a journal, decided your format, it is very important that you go to the journal site that you have picked up and open the instruction to authors page, read it in detail, word by word, and understand what they're trying to say. Because in the very beginning, if you're going to prepare your manuscript for submission according to the editor's authors' instructions for authors, you would be on a right track. You would not have something that we call as desktop rejection. Desktop rejection is that the editor rejects as soon as he sees the article because it does not conform to the guidelines of the journal. Okay. So, it's very important to understand what the editor of the journal would be looking. Of course, we're looking for conformity to the instructions to authors. We're looking for honesty and clarity. That's very important. And ethical issues make a cornerstone of any journal. So we live in times where we are under constant moral as well as ethical scrutiny, and therefore having at least an institutional ethical board approval, a patient approval, especially if you are doing a case report, presenting a case report of a person. And of course, in today's times, we're also looking at CTRI. So if you're doing a randomized controlled trial, a central trial registration of India is something that you register prospectively at the time when you are preparing your protocol, and then you can do your study and you constantly update your data and your findings into that trial registry. So a valid number of that, an institutional ethics approval, and of course patient consent if you are taking specific patient data. Remember, blinding patients' details is extremely important in case reports if you're looking at. Another thing is very important is authorship issues. More often than not, we do that you scratch my back and I scratch your back. So we're not going to do that. It's very important that there are very clear guidelines on who an author can be. We need to go to the International Council of Journal Medical Editors website or their page to look at what makes an author. How do you actually qualify to be an author, and then you should be an author, right? And of course, need to state your conflict of interest or financial interest if there are any, and we should not try to hide them, because if they are found at a later stage, that would, even at a stage where your article has been published and you find the editor comes across any of these ethical issues, this qualifies for a retraction of your article, and of course rejection if it is still in the process of publication or review, right? So as I said, we are looking for honesty, we are looking for clarity in the paper, in the manuscript, accurate things. Of course, we do not want volume, so brevity is very important, and hence comes structure and uniformity, and of course, needless to say, novelty and valid science. Okay, so the best thing that fits into whole of this, especially for research papers, is an IMRAD format. This was, of course, introduced by Sir Bradford Hill in 1965. It's a standard structured format which enhances the comprehension and clarity with no repetition. And as I said, it also conforms to the International Council of Medical Journal Editors and most international scientific journals. So what does IMRAD basically stands for? It's a structure for a manuscript, especially a research paper, which has components of introduction, methods, results, and then of course the discussion. So it basically tries to answer, why did you start? What's your rationale? What did you do into your method section? And what did you find? And what does all of that mean? So it's basically, you're telling a story in a more structured format. That's what we are looking at. And of course, there are a few things that go ahead and after the IMRAD, and that is, you will have a title, you will have an abstract, you will have some keywords, and then of course, conclusion and references and acknowledgements if there are any. So all of these make it a complete structured uniform pattern for preparing your manuscript. Now, when I come to the title, you have to remember that your title needs to be simple, informative, and concise, and should try to reflect the hypothesis that you have attempted to answer in your research. Remember that this title will be used by databases for indexing, so that when future researchers are trying to find out, your title and your keywords should be, kind of searchable, and you should avoid witty and grandiose titles. That's very important. An example is, just to give you an example. So if there is a study which has compared the effect of various positions of on the incidence of bradycardia during recovery period in patients undergoing surgery under spinal anesthesia. It's a longish title, but it of course tells us what exactly the authors are trying to do. Another way to make it more concise and still give the entire information is to concise it to say bradycardia during recovery from spinal anesthesia, incidence and effect of patient position. So a kind of a balance between the two is something that an editors would be looking at. And it's a good idea to go and look at the articles published in that journal and look at how they have structured their each aspect of the manuscript. Then after the title comes the abstract area. Of course, an abstract is something that you write later on, right? But what is very important is that the abstract is usually, the kind of the showcase of your article. Most of your readers are going to read the title and the abstract and then decide whether they're going to read the further on your article. Similarly, reviewers are first going to look at your abstract and the title and then proceed further. So needs to actually reflect accurately and succinctly. It's a summary of your entire paper. So should be well structured, should follow the guidelines, of course, as I said, of the journal. Should have no references and should accurately reflect what you are actually doing and what you have done and what you have found. Okay. So this is just an example of a structured abstract where they have structured the abstract into background, which tells why they did the study, then the material and the methods. And of course, it is briefly written so that it reflects what exactly was studied and how did you, what were your key observations, what did you do, how did you do them, and what are your key observations, and how did you analyze your data, and the main results with conclusion, and of course, the key results. So these should be, as per most of the journals will give you a structure and you should try to follow it. Then beneath the abstract is a keyword section, which of course would be some 3 to 10 keywords or short phrases. It is good that if they are kind of, follow the medical subject list of Index Medicus, because they will help you in cross-indexing and of course should be able to capture the main topics of the article. So if I were to look at this paper, so they are basically looking at intraoperative dexmedetomidine infusion on sevoflurane requirements and blood glucose level during entropy guided general anesthesia. So the key elements of this which would form is the use of dexmedetomidine and sevoflurane on blood glucose levels using during entropy guided. So these are the key areas that they have used to make their keywords. Now, coming to the main part, that's the introduction, the IMRAD format. So IMRAD format is basically, if you kind of remember, it is something like an inverted pyramid where you first say what has gone before in this particular area of research or this particular area of your topic before you into the literature. So what is the available literature? And then you talk about so it's a very, very brief abbreviated review of literature. And then you state what are the gaps in the literature, and that makes and why did you frame your hypothesis and what your hypothesis actually is, the rationale of the study as we call it. Okay, so you move from a broad statement why we did the study, and then of course you arouse the interest of the reader into the rationale of the study by stating the lacunae in the literature, and then you state your hypothesis. So you need to be logical, you need to have a flow, you need to write it in present tense, and of course remember that if you're going to use any abbreviations now into your manuscript, this is the time that the first time you use that abbreviation, you give the entire full form of that abbreviation and write the abbreviation in parentheses and then use the abbreviation later on in the entire manuscript. But what is most important is, as soon as your reader reads your introduction, they should be able to understand the importance of your study. Why are we doing and what are we trying to find there? So very important is that do not give shocking statements, do not provide very extensive and historical details. Most of the times, if you're looking at, say, a study looks at incidence of hypotension, maternal spinal induced hypotension, they start from when the spinal was introduced into anesthesia, and then you go to when we use it in obstetrics, and then that is not what the reader or the editor or the reviewer is looking at, right? So we need to be very precise into why am I studying maternal spinal induced hypotension and what aspect of it am I studying, what is the lacuna in the literature. So we need to be more precise and focused into this. So once your readers know where they are, now they need to know how to go about it. So that comes to the method section. And as Dr. Rakesh Garg told you, it should be replicable. That means it's something like a recipe. It has to have the finer ingredients, talked in detail, with all the clarity up there, so that somebody else uses this methodology would be able to reproduce them into their settings. Okay. And so you need to balance clarity, detail with brevity. And that is something that an art that you learn when you keep doing and keep writing these manuscripts over the period of time. And it's very important that they do have some very important ingredients. And that is one, a statement on ethics approval. As I said, that an institutional ethics approval was taken before the start of the study, that you took informed consent from each of the participant of the study, that the study was registered with the Central Trial Registry. These are the three things that we'll be looking at. And then the reviewer would be looking at the study design, whether it is appropriate with the kind of question that you're testing in the research. Then, of course, you need to state about how did you have selection of your patients, what was your sample size, why did you choose the sample size, how do you randomize and blind them, what were your inclusion and exclusion criteria. Clearly state the primary and secondary outcomes, but in between is very important. How do you went around doing the study? That's also extremely important. So this is something that will be written in a past tense. There'll be a lot of technical information going, and as Dr. Rakesh said, that if you are doing a particular study which encompasses the use of a technique, say you're putting a block using an ultrasound and a PNS, then you need to detail it in a manner that anybody else will be able to replicate into their settings. Okay, so that's very important that we put that whole thing into proper perspective. So remember not to be sketchy in your methods, and do not include the results or your conclusions or your speculations into this. You're only telling them how to do the study. The result section is one, which is the core of your paper. It should be crystal clear, accurate, and have no redundancy up there. So you need to plan and organize and stick to what is relevant. So remember what your primary outcome was, how your data has looked at the primary outcome. And of course, you need to now sort them out. Now you need to give tables and text. Remember, your tables should be able to stand alone, right? So it's very important to select what data will go into which area, whether I need to put a table or I need to put in a kind of a figure chart or a bar chart, or how I'm going to present my data, or I'm going to write down in manuscripts. Put a proper logical sequence of subheadings and state your data up there. And the very important thing is to use the reporting guidelines. So on the Equator Network are guidelines on how to report your various type of publication data. So for most of the randomized controlled trial, editors and reviewers are looking for a consort flow diagram that tells us how the subjects were recruited, how many were fallouts, how many were dropouts, and how many did you analyze. And then, of course, your statistical precision must be appropriate. And remember, at the end of your at the end of your method section, there has to be a small paragraph that tells how do you statistically analyze. I think that will be taken up by my subsequent speaker. Some of the few common mistakes that we must remember here is that they should avoid repetition of data in text, tables, and figures. That's too much of data coming in. A mismatch in the number of texts and tables. So remember that tables need to be, cited in your text in a sequential manner, and of course there should be no mismatch up there. And then suddenly what we realize is there should not be any omission of results of one or more parameters or inclusion of results of parameters which are not mentioned in the method section. So you have to clear what you observed and in the method section, and those are the results that we are going to talk about. I'm not going to talk something that has come up new, or you might decide to omit a result because it did not conform to your plan of things. So that is also not to be done. And we do not write interpretations or conclusions or neither references. So this is just stating what you found in your study. Now the discussion section is one which tells about what does all this methodology and the results mean in the context of the entire gamut of available scientific evidence. So it's a kind of a pyramid. It explains the relevance of your findings and puts it in the perspective with other studies and relevant literature. So as a broad guideline, when you write down your discussion, first answer the question posed in the introduction. That is the statement of your principal findings, the primary outcomes. And then you start to relate to existing knowledge, avoiding excessive repetition. Now, it's very important to remember that repetition here basically means that you do not start to again state the results numerically per se again. So you have to be very clear in what is the interpretation of your result and how does it relate to the existing literature. The strength and the weaknesses in relation to other studies should be honestly written down. And of course, in the end, we talk about unanswered questions and what we think that they can be ideas for future research on this particular area. Now, very important to remember some common mistakes that really irks a lot of reviewers and editors is this is the first study in the world. So be very sure that when you're submitting, you have done a literature review again, because by the time you had a plan ready and then you did your study and then of course you published, there's a lot of time that has elapsed. So there might be studies that have already been published during this time period. Therefore, doing a review just before submission is extremely important on your topic. Emphasizing the strengths of the study more than the weaknesses. Any editor or reviewer would be easily, will be able to find out that you have tried to underplay your weaknesses. So that's something that we will not do. Neither will we have unjustified conclusions. So conclusions at the end of your discussion should be solely based on the results of your study and not on somebody else's things. And of course, as I said, repetition of results need to be avoided. A word about tables. As I said, they should have the ability to stand alone. And when I say stand alone, it means that they should have a title. They should have proper rows and column headers, which tell what exactly the material is inside. And of course, if there is a footnote, they should be explanatory. So looking at the table, we should be able to make out what is it talking about. And each of this table needs to be cited in the text. Most of your manuscript submissions will need the tables to be submitted either separately or towards the end of the manuscript, but their numbers need to be cited into the text. And of course, need to be tight as per the guidelines. Illustrations, very important to remember that if you're using photographs of patients, two things are important. You need to blind them, and you need a written permission from the patient or their, in case of children, their parents or their caregivers for publication, which is separate from a consent for anesthesia. Remember that. And then figures, of course, again, need to be self-explanatory, well-labeled, numbered, and there has to be a legend to all figures, and many a times are required separately. Now, the most important section in which forms a reason for many revisions coming in from editors, even at a later stage, is referencing. I mean, you need to include not the entire plethora of evidence that is available as references, but only relevant, accurate, and complete references. It's important that we do not self-cite ourselves. And of course, we have relevant references to each of the point. And very important to remember is that you should follow what the guidelines, and most of the journals are going to follow the Vancouver system for referencing. So you need to go in there and look at the examples that they have given, and then of course use the citation formats and do the citation. So write in what order, I gave you the entire thing up there. So the best thing is that you have your title, then you have your methods, write your results, then do your introduction and discussion. And then after you've done this entire manuscript comes your abstract, and of course, followed by your acknowledgement and references. So this is how you would actually start writing. Once you have written and you're ready with your manuscript, keep it away for some time and then go and revisit it. And in that time period where you have left it away for some time, give it to your friend to read it and see whether they can make sense of it. And before submission, check what are the requirements. Some of the common requirements are covering letters, a conflict of interest statement, a copyright form which is duly signed by all authors. Some of the journals would require an IEC approval or a CTRI number form, scanned form up there. They would like to have a look at that. A title page, and of course, a blinded article file. A blinded article file is a file where your manuscript is there, which has your abstract, the title, the keywords, and the IMRAD format of your manuscripts with references, which will not have any identifiers of you yourself. One of the most commonest mistake authors make is in the method section, they'll write the study was done at Danan Medical College and Hospital, Ludhiana or Flana, or whatever the institution's name would be. Remember that this becomes an identifier. So this should not be there into your manuscript. And before you submit, check your file at your level for plagiarism. Plagiarism calls for outright rejection. So it's very important that you learn how to avoid and not to have plagiarism creeping into your manuscripts. And then again, revisit the instructions to authors and then see whether you actually conform with it. Okay. So it's very important that you write your article, then you give it a breather where you give it time and revisit it. And then of course, keep polishing, pruning, and then go ahead and do it. Okay, so this is how we go about doing our article writing. It's something that takes time. It takes a lot of passion to do it. And so these are the few tips that creating an art is up there. So you all can indeed, you all are much more experts than me, but then very important, and I'm repeating it for the sake of, repetition, despite the repetition, is because these are things that can call for rejection. So reading instructions carefully, filling out the necessary forms, plagiarism report, and of course, then submitting it. And when you're submitting, and remember that you will either have acceptance, rejections, or revisions. But whenever you get revisions, try to respond to the comments promptly and in detail, in timely manner, point-wise. And do not add new data during revisions. That's very important because that calls for, again, a big scrutiny and rejection. Some of the rejection criteria are poor experimental design and redundant studies, duplicative studies. You have submitted to 2 journals is something that journal editors are not going to like, and you live in world of Google where these things are easily, traceable. Fabrication and plagiarism, and of course, all of these are something that should be avoided. Okay, these are all reasons for rejection. So a poorly written manuscript is one of the most important reasons for rejection. So your criteria for are something that Dr. Rakesh Garg talked about: originality, new information, your methodology following the PCOT criteria, and adhering to the elements of finer, right? Whether it is novel, ethical, relevant. So all of these together makes the correct ingredient to be published into a journal. Remember that journals also need papers as much as authors need acceptance from them. So it is a both-way experience that we all have. Thank you so much for your patient hearing. We would love to answer questions if there are any.
Yeah, thanks a lot, madam.
It's extensive and detailed. I do not know how much went in.
No, the part 2 is more important than the part 1 because you are the one as editor who is going to accept after the implementation of research. So a lot of carry home in all the slides. I think this is available in YouTube also, and our participants in today's program can also go through it later. And we'll take up the questions at the end of the third session. So we have Dr. Shivangi. She has been allotted probably the difficult topic of the day. In the sense, of course, it's the basics, and even the basics are very important. So I hope our PGs would take some important tips related to the basics of statistics. Dr. Shivangi, you can just start your presentation.
Sir, my slides are visible.
Not yet, please. You have to start sharing. Yeah, it's seen now.
Okay, sir.
Yeah, advance, please.
Thank you so much, sir. Good evening, everyone. Thank you, Rakesh, sir. Thank you, Anju, ma'am. It was a very informative lecture. I welcome all the delegates who have joined us today on the webinar. I'm Dr. Shivangi Ganju, DM Senior Resident in the Department of Onco Anesthesia and Palliative Medicine at IRCH AIIMS Delhi. And I'll be talking about basics of statistical tools. Now, why is an understanding of statistics important for us as anesthesiologists and intensivists? So we know that advances in anesthesia and intensive care rely upon development of new drugs, techniques, and equipment. Evaluation and clinical application of these advances rely critically upon statistical methodology. And an accurate and reliable statistics is essential for a good quality research. So whenever we are starting with a trial or a study, we are collecting the data. What we have is the raw data. And to get the results, it has to undergo a statistical analysis. Only then we'll reach to some conclusion. So that is the part of statistics. And I'll be talking about the basics in the few 15-20 slides. So the first thing that we need to know is the kind of data that we have, the type of observations we have. Only then can we decide what type of tests we are going to apply to the data. So before a research study is undertaken, it is important to consider the nature of observations to be recorded. It determines the way in which the study observations are described and which statistical tests will eventually be used. So data is broadly classified into two types, qualitative and quantitative. And qualitative data, it is further classified into nominal, ordinal, and quantitative data is classified into interval, scale, and ratio scale. So I'll start with nominal data. As the name suggests, nominal data means names, and this can be best described by grouping the observation into categories and counting the number in each. For example, number of males in a group, number of females in a group. So this can be reported using an absolute count or in the form of percentages, rates, or proportions. So examples are gender, race, adverse cardiac events. So we are describing the data as percentage, rate, proportion, or absolute count. Next is ordinal data. Now, when the data is in a natural order among categories, so that there is a relative value among them, generally from smallest to largest, you have a grading, you have a classification, you have a score. So you are looking at ordinal data. So I've given the examples like TNM staging, ASA classification, pain score, scoring 0, 1, 2, 3, 4. So no pain, mild pain, moderate pain, severe pain. This is an example of ordinal data. Now here, score 2 does not mean that it is double of pain score 1. Also, the difference between scale score 2 and 1 is not equal to score 3 and 2. So that difference, that relationship among the data is not there. If we are seeing such a relationship in the data, we are actually looking at quantitative data. So first one is interval scale. As I said, they have meaningful intervals, meaningful order. For example, temperature in Celsius scale. Now, the difference between 90 degree and 100 degrees Celsius is the same as the difference between 60 and 50 degree. But here, it does not have an absolute zero, which means 0 degrees Celsius does not mean absence of heat. Also, 50 degrees Celsius does not mean it is twice of 25 degree, 100 degree is twice of 50 degree. So if such a relationship is there with the data, that will be seen in ratio scale. So that is the difference between interval scale and ratio scale. So ratio scale, I'll cite some examples. For example, weight in grams. So 50 kg, 50 grams is double of 25 grams, and 0 gram means no weight. Time in seconds, blood pressure measurement in millimeter of mercury, pulse rate. These are all examples of ratio scale. So they have same properties as that of interval scale. That is, these are examples of quantitative data, but it has an absolute zero. And the only temperature scale that follows interval scale is Kelvin scale. After knowing the data that we have, next I would like to talk about central tendency. So the data that we collect in a sample, the observations, they cluster around a central observation. And how do you measure that? It can be done with the help of mean, mode, median. So mean, we all know it is the sum of all the observations divided by number of observations. Mode is the most frequent or most common observation among the whole data. And median is the middlemost value when you arrange the data in an ascending order or a descending order. If you have two middlemost values, an average of the two will give you median. Now, this mean, median, and mode, they will be equal if your data is normally distributed, which means the data is symmetrical. The middle image you can see, it's a normal Bell's curve where mean is equal to mode is equal to median. But if the data is positively skewed, that is, mass of the distribution of the data is concentrated on the left, in that case, mean will be greater than median, and that will be greater than mode. And if your data is negatively skewed, which means mass of the distribution is concentrated on the right, in that case, your mean will be least, and mode will be greater than median, that will be greater than mean. After central tendency, another entity is measures of dispersion. The data, the observations, how much they are varied or how much they are separate from the central value will be depicted by measures of dispersion. So measures of central tendency, they are not adequate to describe the data. Two data sets, they can have the same mean, but they can be entirely different. Thus, to describe data, one needs to know the extent of variability, which means how dispersed the data is. That can be measured with the help of measures of dispersion. The common ones used in statistics are range, variance and standard deviation, coefficient of variation, and interquartile range. So I'll be telling about them. Range is simplest of all. It is just the difference between your largest value and the smallest observation in the sample. It is easy to calculate. Variance is the arithmetic mean of squared deviation from the sample mean. So this is to see how closely each individual observation clusters about the mean. And if you take out the square root of variance, you get the sample standard deviation. And standard error is standard deviation divided by under root of n. N is the number of observations. So that is the value you get for a population. So that is also a measure of dispersion. Interquartile range, if you divide your data into three quartiles, the difference between the 25th and 75th percentile, which is also called the first and third quartile, is known as interquartile range. So basically, this describes the middle 50% of observations. Coming to coefficient of variation, this considers the relative size of standard deviation with respect to mean, and the formula is standard deviation upon mean into 100. Okay, now one of the confusing aspects of statistics on which there are a lot of PG residents and DM residents with us, so you will get a lot of MCQs in the research methodology exam, which has been made mandatory in the curriculum. So how do you decide which statistical test to be applied on the data that you have? So basically, you classify statistical tests into parametric and non-parametric. You have to run parametric tests when your data is normally distributed. You have quantitative data. Quantitative means you have ordinal, you have interval scale or ratio scale, and you're comparing means in the two groups. Examples of parametric tests are students paired t-test and students unpaired t-test, and last one is ANOVA, and I'll be citing examples for each later. Coming to non-parametric tests, these are based on non-normal distribution, wherein you are dealing with the data which is qualitative, that is ordinal or nominal, and you are comparing percentages, proportions, and fractions. So the common ones used are chi-square test, Wilcoxon test, Kruskal-Wallis test, Fisher's test, and Mann-Whitney test. So I'll be talking about each test and giving one example each so that we have an idea of how these tests are different from each other. The first one is the student's t-test. It assesses whether the mean of two groups are statistically different from each other. So you can see a control group, you can see a treatment group, and the two means. We are comparing mean of the two groups. Here also we have two types of t-test. One is unpaired and paired. So depending upon whether we are dealing with two independent groups or we are dealing with a single group in which we have given an intervention and we are comparing before intervention and after intervention values. So we have two types of tests. In both the cases, we actually deal with the interval ratio data, that is the quantitative data. So unpaired test, you are actually comparing mean in more than 2 different individuals. For example, if you are comparing mean hemoglobin level of anemia, that was 9.6 gram per deciliter, and those of hookworm patients, it was 7.2. Now, if you're comparing the mean HB levels of these two set of patients, you are actually comparing mean in 2 different groups. So comparison of means in this case can be done by unpaired students t-test. Now, another example of paired t-test. For example, you are comparing mean serum albumin level of dengue patients before treatment is 3.6, and after treatment, it was 3.2. Now you are comparing the mean levels before the treatment and after treatment. So which test to apply? Here you will be applying a paired t-test. So this is to compare the mean of 2 small paired samples. That is, mean of the same population is being tested before and after an intervention. So basically the same individual is studied in different circumstances. Now, this is an example where you are actually comparing 3 groups. Mean intraocular pressure among different age groups is being given. So what test to apply here? Now, this is the difference is that you are having more than 2 groups. So this can be dealt with ANOVA, analysis of variance. Now, what is ANOVA actually? See, this is similar to the t-test in that it compares means of different groups. So in students t-test, paired, unpaired, ANOVA, all of the groups, we are comparing means. We are comparing the quantitative data. But if you are dealing with more than 2 groups, 3 or more groups, then the test that is to be applied is ANOVA. The analysis is used to see if one or more groups differ from the rest of the groups. And the basic principle of ANOVA is to test for differences among the means of the population by examining the amount of variation within each of these samples. So briefly, we are comparing the means in all these parametric tests. If we are comparing means of 2 different groups, we have to run a student's t-test unpaired. If we are dealing with the same group where you have given an intervention and you have to compare some value before the test and after the test, then you run a student's paired t-test. And if you are having more than 3 groups where you have to compare the means of 3 or more groups, then the test that has to be run is analysis of variance, ANOVA. So these are the common parametric tests. The more trickier ones are the non-parametric tests, where you are dealing with generally with the ordinal and nominal data. The first one is chi-square test. Here you compare percentage, proportions, and fractions in 2 or more different group of individuals. So all those scenarios where you are testing association, for example, you have data where you are given the value that 60% of smokers, they have an association of lung cancer, and 40% non-smokers have an association with lung cancer. So you are supposed to compare the 2 groups. Now the data given to you is in the form of percentages. So that itself is a hint that you are dealing with the qualitative data in the form of percentage, and it has to be chi-square test. So any scenario where testing of association is being done and 2 proportions or percentages are being compared in 2 different groups, the test to be run is chi-square test. Another example I will give, testing a hypothesis that a smaller proportion of people who were immunized against chickenpox subsequently developed zoster than those who were not immunized. So here also we will be comparing the proportion. So the percentage of people who were immunized and developed zoster, we are comparing with the percentage of people who were not immunized and they developed zoster. So we are comparing 2 different groups and percentages or proportions. So the test to be run will be chi-square test. Next is Mann-Whitney U-test. A simple way to understand this test is that it is very much equivalent to the unpaired students t-test. But the only difference is that it deals with the qualitative data. So as it's a non-parametric test, I've already told the distribution of the data will be non-normal and the data will be qualitative. But the characteristic is similar to that of unpaired students t-test, where you are actually comparing 2 different groups. So example, if you are comparing the difference between depression symptom severity in a placebo group and drug therapy group. So you can see you are having 2 different groups. It is the same as you are dealing with a student's test unpaired, but there you were comparing mean, like mean hemoglobin value in one group being compared with mean hemoglobin value in the other group. Here you are comparing the qualitative data. So the depression symptom severity is an ordinal scale. I had told about the ordinal data where you have grading, severity, symptoms, scoring. So such a data, if you're comparing in two different groups, the test to be run has to be a non-parametric test, and Mann-Whitney U-test will be the test of choice. Now, what is Wilcoxon sign rank test? So nothing to worry. It is very much similar to the student's paired t-test, and it's a non-parametric test. So definitely, again, you are dealing with a qualitative data. So again, the same thing. In paired students t-test, we learned that we are actually comparing before and after intervention. The same thing is being applied here also, but the data will not be quantitative. It will be either ordinal or nominal. So example, if we are comparing the difference between depression scores before and after treatment. So scoring, again, it's an ordinal data, it's a qualitative data, and the test that will be applied by the statistician will be Wilcoxon signed rank test. Okay, this is the last non-parametric test, Krusek-Wallis test, and this is very much similar to ANOVA. So a simple way to remember, it is a non-parametric test which is equivalent to ANOVA. ANOVA, we were comparing mean in 3 or more groups. So here also we have 3 or more groups in which we are comparing the data, but the data will be qualitative. So example, the difference in average fitness scores of individuals who frequently exercise, moderately, or do not exercise. If we are comparing this fitness score in 3 or more groups, the test of choice will be a non-parametric test, and that will be Krusek-Wallis test in this case. Thank you.
Yeah, thanks a lot, Dr. Shivangi. I know the difficulty in conveying what is important in statistics within a short time, but you have done excellently well with respect to conveying what is important, especially with relation to the descriptive statistics and outlines of the inferential statistics. Thanks a lot. Before we take up some questions which have been typed in the chat box, let me summarize some important points.
Sir, once again, sir, Dr. Shivangi, you stop the screen share.
Yeah.
Yeah. Yes, sir.
So it was a very exhaustive in terms of the material, but I have to congratulate all the three presenters today because they have been able to put it in a more summarized, but in the sense more interesting way also, using various mnemonics and abbreviations and giving some examples with respect to each of these points. So before we go to some of the questions which have been typed in the chat box, let me highlight some important things, especially for the benefit of the postgraduates here. For example, Dr. Rakesh has presented about the methodology aspect of preparation of the research. This is one thing which we have to be very careful about, because if we have some faulty methodology, we are not going to have a good manuscript preparation, and the chances of successful publication also would come down. So that's one important thing. And if the PGs, especially when they are preparing the thesis under the guidance of their faculty, and when they try to submit the article for publication, these limitations get exposed. So these have been nicely covered by Dr. Rakesh here. For example, straight away when we talk about a research topic, we have to create a research question, and he has very aptly used a mnemonic called FINER, FINER, where it talks about the feasibility of a study, whether there is some, it is interesting, whether there is some novelty, whether it is ethical, and it is relevant to practice. So these are the things which we must consider when we try to pick up research question and go ahead with a research project. And similarly, with respect to the methodology, there is another mnemonic called PICOT, where we talk about the population or the patient or the sample. Then I is for the intervention, C is for the control, O is for the outcomes, and T is for the time period. So this is one thing which is also important. When I talk about time period, it is the time duration of each study itself in terms of individual patients and the follow-up overall. And he has also mentioned about the tools that we use. So tools is very important thing, because he gave an example of even checking the blood pressure. So there are different things of measuring blood pressure, non-invasive and invasive. And in non-invasive, we may talk about the aneroid manometers, or you can talk about the good old mercury manometers. So these are some of the things which have implications when we talk about the results and the discussion aspect also. And scoring system is one which I have also found that people use a little bit, without knowledge, they may create their own scoring systems. It's not acceptable. So for example, we have something like the severity of the pain or the extent of relief of pain as anesthesiologist, or if somebody is a physician, he'll be looking for the reduction in the blood pressure when he treats the patient for hypertension. So we should be having what is known as a validated scoring system, which has been validated by a previous research in a optimal or the best sample size, and only then it will be applicable for any other general use in the future. For example, we are using the modified scales, for example, with respect to the spinal anesthesia, right? Bromage classification. So this has stood the test of time. Just we have modified it a little bit. So we are not allowed to modify this scoring system because this has been validated nicely over the years. Then about the Ramsay sedation score. So it is very well known that this is one of the most validated tools and we keep using it. Again, thinking that I will create a new system, it is not normally acceptable. But if you indeed want to do, we have to have a lot of internal validity, and then normally these things need bigger sample size. And in the last part of the discussion, there is a basically overlap here also. Dr. Shubhangi was talking about variables and Dr. Rakesh was also talking about variables. So this is a simple thing. Variables are the outcomes which we are targeting at. Okay, so this variable is actually a statistical terminology which talks about the various outcomes. For example, I say about the control of the blood pressure. I say about the duration of analgesia. I say about the grading of the motor blockade. So these are some of the things. They are referred to as variables. And definitions also, I told you already. For example, if I want to tell about hypotension, I should be clearly telling that this is based upon the systolic blood pressure definition or diastolic blood pressure definition or mean or blood pressure. Okay, so I cannot be saying that overall hypotension, I checked we decided that the patient having hypotension are noted. So it is normally either a systolic blood pressure or mean blood pressure, depending on the circumstances that is picked up. And ethics committee has been touched briefly by Dr. Rakesh, mainly because of the time constraints. But I would advise everybody to take care that you address the ethics issue. Definitely, it has become more important nowadays. And when you complete the research based upon the advice of the ethics committee, and then subsequently when you submit it for publication also, there is a lot of requirement in terms of addressing the ethics requirement. Then with respect to the part 2 by Dr. Anju Grewal Madam, she has aptly talked about which journal to submit. In fact, one of the questions I think it's related to the which journals to submit with respect to NMC and other things. Of course, we have got difficulty in terms of availability of journals in terms of the quality or the metrics. As Madam was telling, if you want to publish in Indian Journal of Anesthesia or JOACP, we have got limited number of issues and limited number of articles to be published. So not all of us would be able to publish in these journals. So we have to search for other journals. But when we search also, it is important that to note that they are not predatory journals. So I have seen in different places, including my institution, that some of our colleagues in some departments would try to get publication in some journal which is probably and majority of the times predatory in nature. So these things I would generally advise any one of you not to submit to. Then Madam also talked about novelty. So what I would say is novelty definitely would be expected by the editors wherever you submit, because if it is novel, a new topic, definitely it will be straight away assessed for its suitability of publication. But I would also want to stress that as long as you have performed a research with the best methodology, okay, even if slightly there is less of novelty, the editors, we have a tendency to accept it because we will know that a quality research has been performed as per the guidelines, and definitely such researcher is entitled for publication of the data. So this is very important for you to understand. So this I'm stating mainly because that quality of research is very important in terms of methodology, and only if you have got something good in methodology and implementation, it is more likely to be a good manuscript and such a good manuscript is likely to be accepted. And one more mistake which we frequently see is something related to the introduction. Unfortunately, this appears to be more because of ignorance than because of lack of knowledge. We should always explain what is the background for the current research. We should say what is known in the particular field. Okay, then what is the knowledge gap and which you want to address. So this is one which is missing in many of the submissions. So I would again convey this to all the participants. And in methodology, one thing I want to highlight is, apart from the ethics committee requirement, nowadays it is advisable for all of us to register our trials in a clinical trials registry. We have got the CTRA in India. The advantage of this is, of course, this is taken up, such articles which are registered with clinical trials registry are more likely to be taken up by the journals, because majority of the journals want some sort of registration. Somebody has not registered, especially randomized controlled trials, they are not accepted for publication in many of the modern journals. And number two, if you register, it is more likely that people across the world would be able to see your data, and they are also more likely to pick up your article for citation. So this is very important. So what I would suggest is, when you talk about methodology, you talk about at least three things in the beginning. You talk about IEC approval. Number two, you talk about the CTRI registration. Number three, the consent aspects, informed consent and written consent. So the 3 points in the beginning in methodology is very important. And of course, with respect to the preparation of the manuscript and the conduct, Madam mentioned about the Equator network. Please go through this web page and keep it in your homepage also of your browser. It is equator-network.org, where you have got the guidelines for all types of research, starting from even case reports to observational studies to randomized controlled trials to meta-analysis and everything. So this is very important. Please, again, I am repeating, equator-network.org. And with respect to results, please restrict the number of tables and the graphs or whatever. It's not a thesis. If it is a thesis, you have got 10 tables or 10 graphs and more than that, and you have about 80 pages or 70 pages or even 120 pages. But you are going to compress it to about 3,000 words for publication. So we are going to have the most minimum number of tables and graphs. Normally, the journals would also say about 6 would be acceptable for majority of the types of research. Discussion, again, it is expected to be very focused. We are not going to talk too much about everything. Straight away, you are going to type that what are the results in your study, then what is new in your study, what is lacking in your study, and then compare with what has happened in the previous researches. And plagiarism is one issue which has affected us Indians a lot, because very simply, English is not our own mother tongue. We do try to, we try to do the best work, but sometimes we tend to copy. Again, it is out of ignorance from directly from textbooks or journals. So this is not permissible. Please note, we have got free plagiarism software which are available. And as editors of journals, we also have got access to few important anti-plagiarism software also. So please filter it in a free software, then only you decide to submit to the journal. Otherwise, straight away the journals may also reject the article. And conclusion has to be very minimum. I have seen people writing about 15-20 lines. So this is not acceptable. Just focus on the primary outcome, very important outcome, then little bit on the secondary outcome, and finish the conclusion in 2 to 3 sentences. Then coming to Dr. Shivangi's, again, a difficult part of today's presentation. She talked about the qualitative variables and quantitative variables. This you frequently find in publications. People will write this, we applied these tests for quantitative variables, these tests for ordered variables, these for continuous variables and all. But what I would want to convey to everybody is the outcomes which we get. For example, blood pressure. Okay, systolic and diastolic blood pressure. Then, for example, duration of analgesia, 352 minutes plus or minus 32.3 minutes. So mean plus or minus standard deviation. Or we have got number of patients who are relieved of bronchial asthma if you give a bronchodilator. If you say 3 out of 50 patients, or there was no improvement, and another group says about 20 out of 50 patients were not relieved. So these are proportions. So we have got certain important methods of expression in terms of different variables, percentages, proportions, mean plus or minus standard deviation, ranges. So these are all part of descriptive statistics. And we also talk about p-value. P-value, majority of us, of our colleagues have not understood the importance of p-value. In the sense, p-value simply means that something has not happened by chance. Okay. So whatever we do, some results may occur by chance. And the likelihood of something happening by chance would be reduced if we implement the research methodology correctly. So the best research methodology should be associated with the minimum of something happening by chance. And if the p-value is less than certain value, something like 0.05 or 0.01, 0.004 or something like that, normally it is 0.05. Means the results are more likely to be real and not due to chance. So this is the importance of going to you understanding the value of p. And again, she talked about distribution of data and various tests. I know it was difficult for you to understand, but again, just for you to understand, what I am trying to tell is whatever the data you get. For example, you get readings of duration of analgesia in 50 patients. If you plot it in a graph, if you got a nice bell-shaped curve, it is called as a parametric distribution or normal distribution. And if you got something, if it is shifted to the left side or the right side or skewed distribution, we call it as non-parametric or non-normal distribution. So based on this distribution also, certain important statistical tests are applied. So importance of this is, we have to know a little bit of the basics of statistical tools, because when we go to the statistician, biostatistician, I would definitely recommend that you go to the biostatistician. You need not be a specialist here. Then you give a proper input to the statistician. Only when you give the proper input, you are likely to get a relevant test being applied by the statistician, and the tests applied would give a correct result. If you don't do that, an intelligent editor would be, it will be very easy for him or her to find out that you have done some mischief. And again, the article would get rejected. So these are the problems with some of the mistakes which you normally find out. So I would like to go to the questions which have been typed in the chat box. Basically, I think it has increased in the list now. Initially, I found about 3 of them. Shall I go with the questions, sir? Dr. Meenakshi, sir?
Yes, sir. Yes, sir.
Thank you. So we have Dr. Kannan Bojraj. This question would be for Dr. Rakesh. What is the role of blinding in the RCT? How it will be effective in the outcomes of the study? Single, double, triple, which is ideal?
I think blinding is basically when we take some data or when we know that something is being done for this patient, our subconscious mind sometimes can create bias into that monitoring, measurement, or whatever you're doing it. So if we do not know that this patient belongs to which group, we will be behaving exactly similar. This is a human nature. For example, say if I give a block, I will be expecting that I will ask the patient, yes, you must be getting a good pain relief. Patient, especially in Indian culture, if doctor is saying a good pain relief, they should say yes. If you say लगता है कि आपका दर्द अच्छा नहीं है, you are not feeling so much good, you will say yes if he's saying there must be some reason. So this means our behavior sometimes, I'm not saying every time, sometimes can change if we know the group of a particular patient. So for this reason, we want that anything and everything should be blinded. Blinded in the sense that the person who is, say for example, you have done some study for giving a block and you want to look for pain score. So the person who is looking or observing the pain score of this patient should not be aware whether he has received the block or not. So if he is neutral for both the patients, he will be asking exactly in a similar way. And this is what his blinding is. And blinding can be at any point of time. I mean, everybody should be blinded wherever there can be a possibility of bias. So earlier we used to say single blind, double blind, triple blind. So this terminology is outdated right now. So we don't use single blind prospective randomized control trial. We say that whatever you can blind in that study should be blinded, and whatever is not being blinded for whatever reasons, you should disclose into the discussion section, and sometimes it becomes a limitation. So you have to blind everything. For example, if you are using drugs, if they are of same color, same volume, you can just label them A and B. If they have different colors, like for example, if you want to compare propofol thiopentone, they have to be covered. Even during those drugs, some independent person will prepare the drug syringes and give it to you. All the lines should be covered. So wherever and whatever techniques you can use, for example, the tablets, sometimes you know that paracetamol tablet is different from gabapentin tablet, you can easily see. So if you are giving directly to patient, you know that this is a crocin tablet and this is a gabapentin capsule or tablet. So this means you can ask your pharmacy to prepare the similar drug in a similar type of capsule. Or if this is not possible, then the person who is dispensing the drug, he should not be observing the parameters, the outcome parameters for this patient. Somebody else should be doing so. But then again, we say bias can be created. और पूछ सकते हैं कि वो small गोली थी कि capsule था. So patient भी खुद बता सकता है. So that's why this remains an issue, and that's the all research are based on trust. The human instinct can creep in, and that's why we say whatever you can, you should blind. Whatever you cannot, disclose it in the discussion section, that this thing cannot be blinded, though care was taken that an independent observer took all the observation readings.
Thank you, Rakesh. In the sense, again, I would just like to intervene a bit. So at least three things we should be mentioning, doing and mentioning. Doing in the sense we have to implement them, and then mention the same in your publication. That is randomization, allocation concealment, and blinding. So whether you have done randomization or not, and how you have done. Allocation concealment, how you have done, and whether you have done it or not. And in terms of blinding, whether it was possible or not possible, whether one person or second person or the third person was blinded, or whether blinding was not possible, as Dr. Rakesh was telling. So please make sure that these three things are part of methodology and part of the manuscript entry. So this is very important. Then Dr. Anju, there is a question from again Dr. Kannan about mesh medical subject.
The medical
Subject headings.
subject index, yeah. So you actually, you can, these are specific words that you can, when you go to the PubMed and there is a mesh builder up there, and you can actually type your keywords there and see what are the mesh words for that particular phrase or the kind of search that you're looking at, and use those specific phrases, I would say, which are listed up there. So that can help you to use those specific terms than using any other generic words for your specific keywords. That would help in making the search for other researchers more focused, and also for including your keywords into database. So there I think he has actually highlighted, Dr. Rakesh has already highlighted. So on the PubMed page of the National Library of Medicine is this mesh. If you can just show them, it will be great, Dr. Rakesh.
So this is a subsection of the NLM, National Library of Medicine, or the PubMed popularly, which we call it as. So
basically they're using kind of controlled vocabulary, specific phrases for a particular. Yeah. I think there was a question on predatory journals as well.
Yeah. The question was about, the next question was about the PubMed indexing and what are the requisites for NMC. It's a general question, and the predatory journals by Dr. Deepa Tiruvarur.
So I think I did answer about NMJ your NMC has kind of, they keep on updating the guidelines on what are the web indexing agencies that they would accept for promotions and different categories. So that it is best to visit them at the time you're submitting your reports and your data to the promotional agencies up there to see what they are following. Right, I know currently they do follow PubMed as well as NLM indexing and Medline indexing. Remember that PubMed is a repository and not an indexing, but however, it gets listed as an indexing agency. So that's one thing. And then the other thing is predatory journals. And more often than not, because of the promotion policies at various institutions, many of the authors do fall a prey to predatory journals. Predatory journals are usually journals that, you know, offer you a very rapid turnabout with a fee up there. So you have to be really careful. You need to double check their official websites, and also you can check them into NLM catalogs, as well as there is of course some directories and some websites which list predatory journals. But you have to be careful that journals who do not have a proper peer review process are the ones that are kind of predatory in nature. So if you could add more into that here.
Yeah, that is true. At least about 5 to 6 agencies have been shortlisted by NMC. Especially, of course, the PubMed or Medline thing continues. And one thing which has always given confusion nowadays is about, they talk about citation index, where there is some mistake in nomenclature by the NMC, I suppose. And this is taken advantage of by some of our own colleagues, because there is no clarity with respect to this particular agency, so-called agency. So some of these predatory journals, just like the type that there is a citation index, a sign citation or something like that, and there is a tendency to accept by some majority of the inspectors here. This I attribute mainly to the lack of the knowledge related to research methodology and publication, number one, and lack of the adequate number of quality journals also in the Indian scenario, on which we don't have control at this point of time. We can only hope that things become more, quality wise, they improve in the future and more transparent.
But
Then,
in a very, but in a very overview, we can say that any journal which belongs to a professional body or society is usually not a predatory journal. So you just go to the website and see that, say, Indian Society of Anesthesiology, Research Society of Anesthesiology, Clinical Pharmacology. So if it is associated with some professional body, so then be assured and rest assured that it will not be a predatory journal.
That is true.
Yeah.
Can
most of the times, sorry. Yeah, continue.
Yeah, please go ahead.
So most of the times, there is a false, sometimes they do write this is an impact factor, and also the best is to go to either to the JCR reports or to SCI website and recheck it out. Go to your librarian and recheck it out, and ask your senior colleague and find it out, because there are a lot of misleading data on predatory journals website as well.
The only thing is we hope IJA under Dr. Rakesh will add up more pages and more number of articles.
Yes.
Right. Okay, Madam. Then Dr. Shivangi, there's a question for you from Dr. Muthukumar. Please tell what test is followed when we take VAS score for pain and separatist sedation score.
Non-parametric test will be applied because the data is qualitative, but I need to know what you are comparing. Like if you are comparing before and after intervention, VAS score, sedation score, then the test to be applied will be a Wilcoxon test. But if you are comparing 2 different groups, then it will be Mann-Whitney. If you're comparing more than 3 groups, then it will be Crusett-Wallace test. So depending upon what is being compared, but the test that will be applied will be non-parametric, because data is ordinal scale, qualitative.
Okay, so this table would now be available in the YouTube recording also. Why I'm trying to convey is, whenever we talk about study, whether it's a single group study or we have got a comparative trial of 2 or more studies, 2 or more groups, as is shown in this table. So what Dr. Shivangi was telling about, and again what I had expressed about a few minutes ago, was in terms of the distribution of the data. So if they are normal in distribution, we apply what are known as parametric tests. If they are non-normal distribution, we apply what are known as the non-parametric tests. Very simple to understand. And number 2 is whether there are 2 groups or more than 2 groups. So please remember at this point of time, and we can go back to this particular slide, which could be available, which would still be available in the YouTube, and try to understand which tests would be applicable for your particular outcome parameter. Okay, this is a question from to Dr. Meenakshi, Dr. Suresh, and Dr. Periyaswamy. Where can I sign up to get more information about these webinars, Nikhil, Mumbai?
Sir, I have announced they have to SMS their number to me. Already 7 delegates have sent their number. So that is the success of the conference. They want to be a part of it. And for your information, that Nikhil is a third year medical student, MBBS,
So nice.
not a postgraduate. So he wants to know as a third year MBBS whether he can reach to this height. I said, you wait till you become a CRRI just to get sensitized, because it is very difficult for him to know parametric, non-parametric, ANOVA, VAST course, everything. So I think you have created an impact. The faculty have created an impact because of your lecture. They wanted continuous information about this. I have received some numbers, sir. We will take care of that.
Okay, thank you. And there's a question about, please suggest a reference book to understand research methodology and statistics for dissertation. Before I pass on to Dr. Rakesh, Dr. Anju, and Dr. Shivangi, it's very good. Even Miller has got very good material. So very simple for you to understand. You can easily read and take important inputs there. Anything else from Dr. Rakesh, Dr. Anju, and Dr. Shivangi about books for research methodology and statistics?
I think if we see the conventional books, those are more for biostatistician and difficult for us to understand.
Yeah.
I remember there was one issue from the IJ which was fully dedicated to research methodology under editor-in-chief of Dr. Bala Bhaskar. It was in 2017 November, if I remember correctly.
Yeah,
this whole issue was on research topics only. I will, and this is freely downloadable. So just go through it and download all those articles. And these are good for clinician to understand. If you see the conventional books, these are having more language which is more understood by statistical persons. So to put it into a clinical parlance, you can say read your Miller's anesthesia. They have mentioned it very briefly. Download the IJ articles. And you can go on the YouTube, you will find Dr. Anju Grewal's, Dr. Bala Bhaskar's, and there are many other people in India who are giving very good lectures on research methodology and biostatistics. You can download those YouTubes which are on the website of IJ, even RSACP, even Indian College of Anesthesiologists. They're good sessions by many people across India. So go through them, and they are the validated lectures, I can say. So you can believe on them and follow them.
I will tell a shortcut also, Dr. Rakesh. I will tell a shortcut. The delegates can get the email IDs of Dr. Rakesh, Dr. Anju Grewal, Dr. Bala Bhaskar. Then they can learn very easily instead of reading, wasting time on YouTube. Just drop a line or two. Then immediately they will respond. That's what we are doing.
Yeah. Now, one more thing I can suggest is we have the Airway Journal. So IJ, of course, as Dr. Rakesh was telling, we had a separate PG issue in September, I think, 2017, as he's telling. And just about 2 years ago, we had a series of articles on basics of statistics in a journal called Airway, which we are familiar with. Anesthesiologists we are familiar with. It is available on web. It's a Waters Clovers publication. So that has got about 6 to 7 series of articles published by our group. In the sense, our group, which is part of research methodology everywhere. And please go through it. It is very beautifully done, including in terms of what Dr. Shivangi has been was trying to convey in about 20-30 minutes. Please go through those articles, including how the data should be displayed, which type of graph should be used for which type of data, and which statistical test to be applied, descriptive statistics, inferential statistics, everything is clearly available. So please go to IJA and you go to Airway Journal. So this is also a beautiful publication. And purely for anesthesia purposes, actually, there is one specific book by Paul Miles and Tony Jin. It is Statistical Methods for Anesthesia and Intensive Care. So this is a very good book. This I would definitely only advise for the faculty at this point of time. I don't want the PGs to get confused. So this is a good book. Any further input, Madam Anju and Dr. Shivangi? Dr. Anju,
I think it's been very well stated by you. You're absolutely correct. I believe your basic textbooks and then, of course, moving ahead is what is needed. But we really need to understand your methodology first and then, of course, start moving further forward. Learning the basics and tenets of research methodology. And remember that when you write down your protocol is the time where your main work goes in. That's what it decides whether your research is going to be good and publishable also as well. And I think doing a thorough literature search, so learning how to do a good research, reading your articles and being in the journal clubs that we all do is something, a kind of a step that faculty can introduce the students to this.
Yeah, journal clubs and critical analysis of articles should be taken up routinely by the faculty. And anyway, I would suggest that you please attend the research workshops. It could be from any specialty. From anesthesia side, we have been conducting research workshops for the postgraduates. It's a 1 to 1.5 days course where we talk about all the basics. So Dr. Meenakshi can also decide to have something like this in future. Then we have a question about sample size by Dr. Sukhdev. I think we are not deliberately included here, Rakesh.
Yes, sir, because time constraint was there, so we were not able to include the sample size. But maybe I think Dr. Meenakshi Sundaram can have another session sometime.
Already we have opted for the delegates. Dr. Sukhdev is also AIMS professor from Odisha. He is purposely asking for that. I opted Dr. Rakesh. We can have 2 sessions. But Rakesh said he cannot spare time.
We are lucky to have him, sir, because he's just picked up and he won't be available.
Yeah, he said, I was asking him 2-day webinars. He said it is not possible. So Rakesh has become so busy. So we have to wait. We will do that, sir. We will do that. We are, see now the strength of people attending, still they are 131. Yeah. We have crossed nearly 2.5 hours, 8:30, but still 130 members are there. So I profusely thank you. Whatever is left out, Dr. Rakesh can guide. We will place again another. We will place another, sir.
Yes. We'll plan sometime, sir. We'll plan sometime.
We can plan. And there is a last question in the chat box. Dr. Parimala for Dr. Shivangi. In quantitative variables, whether interval scale and ratio scale are same as discrete and continuous variables, please explain.
Interval scale and ratio scale are types of continuous data. And the discrete variable, example like respiratory rate, it will be 12, 14, it cannot be 12.5, 12.6. So that is an example of discrete variable, or post-tetanic count. Continuous data is further classified into what I told about interval scale and ratio. And that I have already described. Interval like ratio scale, the example is Kelvin, temperature measured in Kelvin, and interval scale example is temperature measured in Celsius. So basically, discrete and continuous are 2 different, and under continuous data, it can be classified into interval and ratio.
I hope.
Sir, I will upload the YouTube link within an hour, so that they can pass it on, so that they can rehearse.
Yes, sir. So academic questions are complete, sir, from the chat box.
Right.
Please, you can take over. Thank you very much.
Yeah, thank you very much, sir. Sir, it is extremely good. I personally, and on behalf of ISA, I thank all the faculties. So they have proved their worth. Now I hand over the proceedings to our president, Dr. Suresh Kumar.
Thank you, Dr. A.L.M. sir. It's a very fantastic session we have witnessed today, a long session, but full of practical points. And now it is 8:30 past. I think this is the first CME. We have crossed more numbers and more time and more discussions because of the input of all the 4 personalities, starting from Dr. Bala Bhaskar, Rakesh Garg, Anju Garwal, and Madam Shivani. So I thank once again everybody. I invite our treasurer, Dr. David, to propose the vote of thanks. Thank you.
Yeah, before Dr. David, Dr. President, sir, before Dr. David, I thank all non-anesthesiology postgraduates from Government Theni Medical College. I have checked, all have attended. So I thank their HODs for involving their postgraduates to attend this webinar. It is a special thanks to them. Over to Dr. David.
Good evening to all. On behalf of ISA Pudukkottai, first of all, I would like to thank our academic chairman for tireless effort for successfully conducting online weekly academic program of Pudukkottai Budan. Thank you very much, sir. And special thanks to today's chairperson, Dr. Bala Bhaskar, Professor Vims Ballari, for sharing his views on this topic. Thank you, sir. And I would like to thank today's speakers, Dr. Rakesh Kar, Professor Onco-Anesthesiology, AIMS, New Delhi, and Dr. Anuja Rival, and Dr. Shivangi for excellent academic session. Thank you very much for all. Also thank other faculties and postgraduate for participating in the webinar. And thank Akirola Aeon Logics for technical support. Thank you very much. All.
Thank you. A1 Logics, you can end the meeting.
Thank you so much, sir. Thank you.
Thank you, madam. Thank you, sir. Balabhaskar sir, Rakesh, Shivangi, thank you.